Bismillahirrahmanirrahim. Quote of the day. Prophet Muhammad, peace be upon him, said, whoever is easygoing, easy to deal with, and kind hearted, Allah will forbid the fire for him. Assalamu alaikum. I'm Dr. Nabeela Umar, working as PGR in community medicine. Today I'm going to present the topic which is driving inference from epidemiological study under the kind supervision of Professor Dr. Saida Afzal. The learning outlines are sequence of study designs, type of associations in observational studies, different concepts in the context of causal relationships, guidelines for judging an association, and recent updates. Learning outcomes. At the end of the presentation, participants will be able to describe the various types of associations in observational studies. Also, they will have the concept of causal relationships and will be able to explain the guidelines for judging an association. Approaches for studying disease etiology. If we want to able to draw a conclusion as to whether a substance causes disease in human beings, we need to make observations in human populations. Because we cannot ethically or practically randomize human beings to exposure to a certain harmful substance, we are dependent on non-randomized observations, such as those that come from case control and cohort studies. Approaches to etiology in human populations. Epidemiology often capitalizes on what have been called unplanned or natural experiments. What we mean by unplanned or natural experiments is that we take advantage of groups of people who have been exposed for non-study purposes, such as occupational cohorts in specific industries or persons exposed to toxic chemicals. Each of these exposed groups can be compared with an unexposed group. Examples include residents of Hiroshima and Nagasaki, Japan, who were exposed to radiations from the atomic bombs dropped on both cities in 1945. They were then compared with the residents of Chennai, India, or Tokyo in Japan to determine whether there is an increased risk of a certain adverse effect in persons who have been exposed. This is a sequence of the events when we conduct a human study. The sequence to be frequently followed is the first step is to consist of the clinical observations at the bedside. The second step is to try to identify routinely available data, the analysis of which might shed light on the question. We can then carry out new studies, such as the cohort and case control studies, which are specifically designed to determine whether there is an association between an exposure and a disease and whether a causal relationship exists. If a case control study yields evidence that a certain exposure is suspected, we might next do a cohort study. A randomized trial might be the next step. A two-step process is followed in carrying out studies and evaluating evidence. Number one, we determine whether there is an association or correlation between an exposure and the risk of a disease. And number two, if an association is demonstrated, we determine whether the observed association is likely to be a causal one. What is association? The concurrence of two variables more often than would be expected by chance. Types of association include spurious association, indirect association, and direct association. Spurious association. This is an association which appears due to improper comparison. Observed association between a disease and a suspected factor may not be real. For example, neonatal mortality was observed to be more in the newborns born in a hospital than those born at home. This is likely to lead to a conclusion that home delivery is better for the health of a newborn. However, this conclusion was not drawn in the study because the proportion of high-risk deliveries were found to be higher in the hospital than in home. Indirect association. It is a statistical association between a characteristic of interest and a disease due to presence of another factor that is a common factor or confounding variable. For example, neonatal mortality was found to be associated with maternal age above 30 years and with birth order 4 and above. It was also shown that this attribute B and C were associated with each other. Direct association. The association between two attributes is not through the third attribute. When the study reveals it is not a spurious association, and when the disease is present, the factor must also be present. Types of causal relationships. If a relationship is causal, four types of causal relationships are possible. Number one, necessary and sufficient. Number two, necessary but not sufficient. Number three, sufficient but not necessary. Number four, neither sufficient nor necessary. Number one, necessary and sufficient. In the first type of causal relationship, a factor is both necessary and sufficient for producing the disease. Without that factor, the disease never develops, and in the presence of that factor, the disease always develops. The figure shows type of causal relationship. Factor A is both necessary and sufficient. For example, members of household of a person with tuberculosis do not uniformly acquire the disease from the index case. If the exposure dose is assumed to be the same, there are likely differences in immune status, genetic susceptibility, or other characteristics that determine who develops the disease and who does not. Number two, necessary but not sufficient. In another model, each factor is necessary but not in itself sufficient to cause the disease. Multiple factors are required, often in a specific temporal sequence. In the figure below, each factor is necessary but not sufficient. For example, in tuberculosis, the tubercular bacillus is clearly a necessary factor, even though its presence may not be sufficient to produce the disease in every infected individual. Another example, the relationship of Helicobacter pylori to non-cardiac gastric adenocarcinoma. Although this bacterium is widely regarded as a necessary cause of this cancer, most individuals who are infected with H. pylori do not develop this cancer. In addition to H. pylori, individuals have to be exposed to other risk factors, for example, smoking and intake of food containing nitrates, to develop gastric cancer. Number three, sufficient but not necessary. In this model, the factor alone can produce the disease, but so can other factors that are acting alone. For example, either radiation exposure or benzene exposure can produce leukemia without the presence of the other. However, in this situation, cancer does not develop in everyone who has experienced radiation or benzene exposure. So, although both factors are not needed, other cofactors probably are. Thus, the criterion of sufficient is rarely met by a single factor. Number four, neither sufficient nor necessary. In the fourth model, a factor by itself is neither sufficient nor necessary to produce disease. This is a more complex model which probably most accurately represents the causal relationships that operate in most chronic diseases. An example is that of often non-overlapping nature of risk factor clusters for the development of congestive heart disease. For instance, individuals may develop congestive heart disease if they're exposed to smoking, diabetes, and low high density lipoprotein, or to a combination of hypercholesterolemia, hypertension, and physical inactivity. Each of these congestive heart disease risk factor is neither sufficient nor necessary. Evidence for a causal relationship. Many years ago, when the major disease problems faced by humans were primarily infectious in origin, the question arose as to what evidence would be necessary to prove that an organism causes a disease. In 1840, Henle proposed postulates for causation that were expanded by Koch in 1880s. The postulates for causations were as follows. The organism is always found with the disease. The organism is not found with any other disease. The organism, when isolated from one who has the disease and cultured through several generations, produces the disease. Koch added that even when an infectious disease cannot be transmitted to animals, the regular and exclusive presence of the organism proves a causal relationship. Guidelines for judging whether an observed association is causal. Number one, temporal relationship. If a factor is believed to be the cause of a disease, exposure to the factor must occur before the disease develops. It is often easier to establish a temporal relationship in a prospective cohort study than in a case control study or a retrospective cohort study. The temporal relationship of exposure and disease is important not only for clarifying the order in which the two occur, but also in regard to the length of the interval between exposure and disease. For example, asbestos has been clearly linked to increased risk of lung cancer, but the latent period between the exposure and the appearance of lung cancer is at least 15 to 20 years. Therefore, if, for example, lung cancer develops after only 3 years since the asbestos exposure, it is probably safe to conclude that the lung cancer was not as a result of this exposure. Number two, strength of the association. The strength of the association is measured by the relative risk. The stronger the association, the more likely it is that the relationship is causal. For example, the relative risk for the relationship of high blood pressure to stroke is very high. In a population-based study conducted in Sweden, the relative risk was found to be greater than 5 in individuals with severe hypertension. There is little or no doubt that high blood pressure levels causes stroke. Number three, dose response relationship. As the dose of the exposure increases, the risk of disease also increases. This figure shows an example of the dose relationship for cigarette smoking and lung cancer. If the dose response relationship is present, it is strong evidence for a causal relationship. However, the absence of a dose response relationship does not necessarily rule out a causal relationship. In this figure, as the number of the packs of the cigarettes increase, the mortality rate is also increases. Replication of the findings. If the relationship is causal, we would expect to find it consistently in different studies and in different populations. Replication of findings is particularly important in epidemiology. If an association is observed, we would also expect it to be seen consistently with the subgroups of the population and in different populations, unless there is a clear reason to expect different results. Number 5. Biologic plausibility. Biologic plausibility refers to coherence with the current body of biologic knowledge. Examples may be cited to demonstrate that epidemiological observation have sometimes preceded biologic knowledge. For example, observations on rubella and congenital cataracts preceded any knowledge of teratogenic viruses. Similarly, the implication of high oxygen concentration in the causation of retrolental fibroplasia, a form of blindness that occurs in premature infants, preceded any biologic knowledge supporting such a relationship. Number 6. Consideration of alternate explanations. In judging whether a reported association is causal, the extent to which the investigators have taken other possible explanations into account and the extent to which they have ruled out such explanations are important considerations. Number 7. Cessation of exposure. If a factor is a cause of a disease, we would expect the risk of the disease to decline when exposure to the factor is reduced or eliminated. The figure below shows the data for cigarette smoking and lung cancer. Lung cancer death rates standardized for age and amount smoked among men continue to smoke cigarettes and men who gave up smoking for different periods. Number 8. Consistency with other knowledge. If a relationship is causal, we would expect the findings to be consistent with other data. For example, the figure shows data regarding lung cancer rates in men and women and cigarette smoking in men and women. We see a consistent direction in the curves with the increase in lung cancer rates following the increase in cigarette sales for both men and women. These data are consistent with what we would expect if the relationship between smoking and lung cancer is established as a causal one. Number 9. Specificity of the association. An association is specific when a certain exposure is associated with only one disease. When specificity of an association is found, it provides additional support for a causal inference. Cigarette manufacturers have pointed out that disease attributed to cigarette smoking do not meet the requirements of this guideline because cigarette smoking has been linked to lung cancer, pancreatic cancer, bladder cancer, heart disease, emphysema, and other conditions. The possibility of such multiple effects from a single factor is not in fact surprising, regardless of the tissue that comprises them. All cells have common characteristics, including DNA, RNA, and various subcellular structures, so a single agent could have effects in multiple tissues. Furthermore, cigarettes are not a single factor but constitute a mixture of a large number of compounds. Consequently, a large number of effects might be anticipated. Recent updates. Causal inference challenges and new directions for epidemiological research on the health effects of social policies. Epidemiologic research on the health effects of social policies is growing rapidly because of the potentially large impact of these policies on population health and health equity. This study described the key methodological challenges faced in this nascent field and promising tools to enhance the validity of future studies. In epidemiologic study of social policies, causal identification is most commonly pursued through confounder control, but use of instrument-based approaches is increasing. Researchers face challenges measuring relevant policy exposures, addressing confounding and positivity violation arising from concurring policies and time-varying confounders, driving precise effect estimates, and quantifying and accounting for interference. Promising tools to address this challenging can enhance both internal validity and external validity. Common threats to validity in epidemiologic research play out in distinctive ways in research on the health effects of social policy. This is an active area of methodologic development, with ongoing advances to support causal inferences and produce policy-relevant findings. Rigorous research on the health effects of social policy can be highly relevant to public decision-making. Thus, epidemiological research in this field is likely to grow. In the existing literature, study designs, data sources, policy domains, health outcomes, and population of interest vary widely. Numerous methodological tools are underutilized and are poised to enhance the rigor of research on the health effects of social policies as these methods become more accessible. Methodological development to integrate epidemiologic and econometric methods and to increase the size and measurement quality of dataset will also improve study quality. Causal association between rheumatoid arthritis and celiac disease, a bidirectional two-sample Mendelian randomization study. Rheumatoid arthritis have been associated with celiac disease in previous observational epidemiological studies. However, evidence for this association is limited and inconsistent, and it remains uncertain whether the association is causal or due to confounding or reverse causality. This study aimed to assess the bidirectional causal relationship between rheumatoid arthritis and celiac disease. In this two-sample Mendelian randomization study, instrumental variables for rheumatoid arthritis were derived from a genome-wide association study meta-analysis, and summary statistic for celiac disease originated from genome-wide association study meta-analysis. This study reveals the causality of rheumatoid arthritis on celiac disease, but not celiac disease on rheumatoid arthritis among patients of European descent. This outcome suggests that the features and indicators of celiac disease should regularly be assessed for rheumatoid arthritis patients. The results of this study demonstrated a causal association between genetically predicted rheumatoid arthritis on celiac disease, but did not indicate a causal effect of celiac disease on rheumatoid arthritis. It is challenging to diagnose celiac disease in patients with rheumatoid arthritis since the symptoms overlap in some ways. In summary, the symptoms and indicators of celiac disease need to be considered during diagnosis and managing any rheumatoid arthritis patients. Monitoring the intestinal mucosal events related to articular and extra-articular etiological pathways rheumatoid arthritis may reduce the risk of celiac disease in rheumatoid arthritis patients. Multiple choice questions. MCQ number 1. A public health investigator is studying a rare genetic condition. They identify that a public gene mutation is always present in individuals with the disease and that without the mutation, the disease never occurs. Which type of causal relationship does this observation represent? A. A factor is required but not alone enough to produce disease. B. Multiple factors are needed in a temporal sequence. C. A factor can produce the disease on its own, but others can as well. D. A factor alone produces the disease. Without it, the disease never occurs. E. A factor contributes but is neither necessary nor sufficient. The answer is D. A factor alone produces the disease. Without it, the disease never occurs. MCQ number 2. A cohort study evaluates the long-term effects of asbestos exposure. Researchers find that individuals exposed to asbestos in 1980s show a significantly increased risk of lung cancer 20 years later. What causal guideline is most strongly supported by this evidence? A. Strength of the association. B. Temporal relationship. C. Dose-response relationship. D. Biologic plausibility. E. Specificity of the association. A. The answer is B. Temporal relationship. MCQ 3. A study on cigarette smoking and lung cancer demonstrates that individuals who smoke 40 cigarettes daily have a higher risk of developing lung cancer than those who smoke 10 cigarettes daily. Which causal guideline is being illustrated? A. Increased relative risk of the disease due to multiple risk factors. B. Smoking fewer cigarettes correlates with lower lung cancer rates. C. Lung cancer occurring equally in smokers and non-smokers. D. Equal risk of stroke across different blood pressure levels. E. Consistent findings across population.
B.
The answer is B. Smoking fewer cigarettes correlates with lower lung cancer rates. MCQ 4. Researchers studying leukemia find that radiation exposure can cause leukemia in some individuals, while benzene exposure can independently cause the same disease. Which type of causal relationship does this represent? A. Necessary and sufficient. B. Necessary but not sufficient. C. Sufficient but not necessary. D. Neither sufficient nor necessary. E. Dose response relationship. The answer is C.
D.
The answer is C, sufficient but not necessary. MCQ 5. All of the following are important criteria when making causal inferences except A. Consistency with existing knowledge, B. Dose response relationship, C. Consistency of association in several studies, D. Strength of the association, E. Predictive value.
E.
Yes, the answer is E. Predictive value. MCQ number 6. A surgeon observed that virtually every patient on whom he operated for lung cancer gave a history of cigarette smoking. He was among the first to suggest a possible causal relationship. What should be his second step for an observational study? A. Clinical observations. B. Available data. C. Case control studies. D. Cohort studies. E. Randomized trials.
Available data.
Yes, the answer is B. Available data. MCQ number 7. In a large case control study of patients with pancreatic cancer, 17% of the patients were found to be diabetic at the time of diagnosis, compared with 4% of a well matched control group that were examined for diabetes at the same time as the cases were diagnosed. It was concluded that the diabetes played a causal role in the pancreatic cancer. This conclusion is A is correct, B may be incorrect because there is no control or comparison group, C may be incorrect because of failure to establish the time sequence between the onset of diabetes and diagnosis of pancreatic cancer, D may be incorrect because of less complete ascertainment of diabetes in the pancreatic cancer cases, or E may be incorrect because of more complete ascertainment of pancreatic cancer in non-diabetic persons.
It's A is correct.
The answer is C. May be incorrect because of failure to establish the time sequence between onset of diabetes and diagnosis of pancreatic cancer. MCQ number 8. An epidemiologist observed a strong link between human papillomavirus and cervical cancer, supported by evidence showing that the virus integrates into the DNA of cervical cells. Which causal guideline is illustrated in this scenario? A. Biologic plausibility. B. Specificity of the association. C. Dose response relationship. D. Temporal relationship. Or E. Replication of findings.
A.
Yes, the answer is A. Biologic plausibility. MCQ number 9. Prevalence of Helicobacter pylori in patients with duodenal ulcers is 90% to 100%. However, it is found in some patients with gastric ulcers and even in asymptomatic individuals. This type of association is A. Temporal relationship, B. Strength of the association, C. Dose response relationship, D. Replication of the findings, or E. Specificity of the association.
E.
Yes, the answer is E. Specificity of the association. MCQ number 10. A cohort study investigating hypertension and stroke reports a high relative risk for individuals with elevated blood pressure. What does this observation indicate about the association? A. Biologic plausibility. B. Strength of the association. C. Temporal relationship. D. Dose response relationship. Or E. Cessation of exposure.
B.
B.
The answer is B. Strength of the association. This is the key to the MCQs. This is the YouTube channel where the presentation will be uploaded. Thank you.